Today we have Dr. Alika Lafontaine, who will be exploring how bias influences patient care and how personal beliefs contribute to the outcome of Indigenous patients. So Dr. Lafontaine is an anesthesiologist and medical lead for the North Zone with the Aboriginal Health Program. He is a national advocate for Indigenous health and serves as Vice President of the Indigenous Physicians Association of Canada, Representative Forum of the Alberta Medical Association, and a member of the Indigenous Health Advisory Committee of the Royal College of Physicians and Surgeons of Canada. He also has academic appointments with the University of Alberta and First Nations University of Canada, and Dr. Lafontaine's research focuses on issues of bias, racism, and discrimination affecting Aboriginal patients. So I'd like to welcome Dr. Alika Lafontaine, and I will pass it over to you, Alika.
But thank you all for attending. I've been doing these talks for the past 5 or 10 years in different forms, and I'm really excited that Alberta Health Services has made space for this, and thank you for Chelsea and the Aboriginal Health Program for supporting this. We're going to go through kind of not seeing what's in front of us, racism in health. If you notice in a lot of health literature, we never really call racism in a lot of papers. We often call it perceived racism. And there's a shift that's going along in medicine right now where we're now able to confront this. I don't think we could have really done this specific presentation even 5 years ago now. We're going to talk about bias as an intrinsic part of the health experience, power differentials in medicine, and then things about how we can fix things and where we go from there. So I'll just go through quickly the other roles that I have. I'm with IPAC, the Royal College, the AMA, and I'm also a management consultant with a group called Indigenous, just to declare those other roles. So there's a world out there that we don't see. And it's not that we don't mean to see it, it's that we actually can't see it. Scotoma is a medical term that talks about a partial loss of vision or a blind spot in an otherwise normal visual field. It's a normal progression that occurs when people have neuromuscular disease or other types of conditions. And as we grow and develop in our society, we develop these sorts of filters that create these losses of vision or blind spots. I'm going to show you a paragraph in the next slide. Some of you have seen it before, so try not to spoil a surprise for other people. I want you to count the F's in the paragraph. So you can have about 3 seconds, all right? So here's the paragraph. Take some time, read through, and count the F's. So 1, 2, 3. So usually when I do this in person, I ask people to raise their hands as far as who's only seen 3 F's. So I can ask my room, how many people saw 3 F's in this paragraph? Raise your hand. How many people saw more than 3 F's? More than 3 F's? So that's probably what usually happens. About half the room ends up seeing 3 F's, and then everyone else sees 3 or more F's. So here's the F's.
Oh my goodness.
So some people are surprised when they see this, but in our educational system and the way that we learn reading, when we read, we're trained to look for big words, right? Especially if we're told that we have a limited amount of time. So we look to the big words, finished, filed, scientific. But we tend to skip over the ends, the does, the ofs, because we're told that they're not important, right? We're reading for context. So that's the first reason that's common. The second reason is that when we read in our head auditorily. So we make the sounds in our head. So the F's in finished and files sound like F's, while ofs sound like V's. So when we're reading quickly, our brain tends to filter these things out. So I'm going to show you another slide. There's going to be 3 triangles. I just want you to read them quickly, left to right. There's going to be 2 on the bottom, 1 on the top. And just try and read them quickly over 3 seconds, okay? So here's the slide. So just read triangle 1, triangle 2, triangle 3. So most people end up reading Paris in the spring, once in a lifetime, and bird in the hand. But what does it actually say? It says Paris in the spring, once in a lifetime, and bird in the hand. So I use these 2 exercises to illustrate that even when you're told that there's a trick, even when someone has just told you that you can't see something in front of you, you still can't see it. And that's the majority of people. And that's just the way that the human brain works. So the question that I ask in my presentation is, do we have a racist healthcare system? I think all of us in our experience, and I'll include the other isms, not just racism, ageism, sexism, classism, all these things. I mean, it exists in our healthcare system, right? And it exists because bias and discrimination exists. It exists because we're people, right? Now, what makes the healthcare system unique, though? So the number 1 complaint of First Nations and Métis patients in the North Zone is hostile health environments when accessing care. There are natural processes that promote bias in medical environments. So our system is designed to categorize and assign. As healthcare professionals, we're trained to diagnose, and categorizing, assigning, and diagnosing, they're all types of profiling, right? We're taught to look for patterns. A good diagnostician should be able to see a patient and come up with a working diagnosis in a fairly short period of time. And this has actually been shown in research. So this research comes out of Yale, Stanford, various places across the United States. And it's found that in as little as 10 to 18 seconds of meeting patients, we've kind of already decided what their problem is, for better or worse. The Institute for Healthcare Improvement down in the States has called this the 18-second rule. And it's the amount of time that it takes for a medical professional to interrupt you while you're telling the story of why you're actually there. All right, so in a fairly short period of time, we've kind of already pegged the patient as having something or another. When we look at Indigenous patients specifically, there's a lot of bias that healthcare practitioners and any person within the healthcare system actually arrives to the healthcare system with. Indigenous peoples are viewed as uncivilized by early settlers. This is still taught in mainstream medicine, mainstream media, mainstream medicine. If you look at Hollywood movies, Dances with Wolves, all of these other movies. That's kind of the idealized Indian that's taught, right? Popular belief is that there were very few Indigenous people prior to settlers arriving. This reinforces disempowerment. There are actually hundreds of thousands, perhaps millions of Indigenous people based on historical records and new things that we've learned. Historically, Indigenous people are characterized as primitive. They had little technological or scientific advancement. One of the things that's commonly taught is, Indigenous people may have created the wheel, but they didn't know how to use it. There are a lot of medicines that are actually out there that we use commonly, digoxin, Senecot. I could go on to list 10 or 20 just off the top of my head, where those were taken from traditional medicine practitioners. There was some sort of patent attached to them, and they were mass pharmaceuticalized. Right? So there are many, many, many things that we use in modern day medicine that originally came from Indigenous people. But how many people who are listening into this call have ever heard of an Indigenous champion in Western medicine? Or an Indigenous scientific champion, someone who helped us change the way that we, do agriculture or other things. These are all areas where Indigenous people have contributed quite a bit. Medical research emphasizes that Indigenous people in Canada have the worst health outcomes of any ethnicity in Canada in nearly every measurement. So people are coming already feeling this way about Aboriginal patients before even talking to them. And we're moving towards the social determinants of health as the new narrative to reframe this discussion. But there is a huge caution. This can be strongly misinterpreted or poorly understood. This is from the Canadian Medical Association website. And the question that I'm going to ask is, based on this graphic, is there an implication that there's something intrinsically wrong with Indigenous people? They ask the question, what makes Canadians sick? So the first thing says your life. Income, disability, race, Aboriginal status. So is being Aboriginal something wrong with your life? Do I think that they meant it this way? Probably not. But is that the implication that you kind of draw? If you sit and think about this, it does make some sense. So what do we actually believe about Indigenous people when they come to see us? These are common caricatures that I think most people can identify with. Unemployed, don't care about their health, frequent flyers, so people that utilize the healthcare system regularly. They won't understand explanations, difficulty speaking English, they'll be aggressive, non-compliant, drug and alcohol abuse, various psychiatric disorders, communicable diseases, HIV, hepatitis, etc. MRSA. It's interesting in our screening for MRSA that simply being Aboriginal makes it so you must have a swab. They don't actually check postal code.
I see.
So if I came in as, a high-level learner with, 12, 15 years of education, I would be swabbed, strictly because I'm Korean Ojibwe. Abusive home environment, lazy. So how are these beliefs expressed? And we talked about this a bit when we viewed that video. Avoidance, shaming, being ignored, distrust of patient histories, There was a recent experience by a patient that they shared with me. They sat down to talk to a physician, and they came in with liver failure. Now, the causes of liver failure are pretty wide, right? And I'm not going to go through the whole list. I'm not interested. But alcoholism is, of course, one of them. And they were asked no less than 20 times, are you an alcoholic? They have never had a drop of alcohol the entire time that they've been alive. But the emergency practitioner who had met them was sure that they were hiding the fact that they were an alcoholic. And they were sure that this was the reason. Now, does that cause other problems? Well, it does when you get set on a diagnosis and you don't explore other causes, right? If you don't do tests for other causes of liver failure, can you actually treat those causes? Forcing patient care on patients. So, we encourage patients, quote unquote, to do what we want them to do on a regular basis as physicians in particular and healthcare professionals in general. But actually not giving patients choice. Withdrawing care from patients. You're a difficult patient, I'm not going to see you anymore. Segregating Indigenous patients from non-Indigenous patients. We actually talked about this right before the presentation started. Why are Indigenous patients kept in a separate room? And often we tell ourselves benevolent reasons why that's the case, but are there other more negative reasons why we might be doing this? And then treating patients how we expect them to respond instead of how they actually are. Are we treating them as a caricature, or are we treating them as an individual? So this seriously does happen. When we look at postal codes, you'll be down in Emerge or in outpatients or in the OR and holding, and you'll see a postal code and you'll say to yourself, oh, well, that person's from there, so they must be this way, right? And this doesn't just happen to Indigenous patients. This happens to any other of our ethnic populations. Up in Grand Prairie, we have a lot of Mennonites. There's French colonies. I mean, the same sort of thing can happen to them as well. When we look at last names, even if we get rid of postal codes, if the last name is Horseman, rough reserve. So an experience that was shared with me by a healthcare professional was in high level, kind of the rough reserve near there is Assumption. So if you come to Assumption, you must have this long list of problems. When we do handover in the operating room, often we do it on speakerphone, especially if we're in the middle of a surgery. We often don't do it when the patient's awake, but if they're getting a general anesthetic. So on the phone, this is a 22-year-old Aboriginal patient. Do we say that in other handovers? Patients with the right or wrong look. I've had patients, mothers come up to me and say, my son had long hair, looked First Nations, and had tattoos. So they kept on asking me, are you abusing drugs? If we're told that we have a difficult patient from a colleague, do we actually critically analyze that? Do we ask our colleague, why is this a difficult patient? Or do we just start to treat that patient that way strictly because of an unfounded statement that we're told? So when we're looking at power differentials in medicine, one of the things that I commonly talk about is that power usually comes from three sources. And you can categorize this a bunch of different ways, but I usually use information, financial, so money, and then the ability to hire and fire. When you look at patients and the control that they have, they really can just walk away. So they either choose not to present or they choose to leave, right? So if someone chooses not to present, the system actually penalizes them by saying, well, you're a frequent no-shower, so we're not going to give you access. We're going to force you to go find somewhere else, or we're going to force you to pay a no-show fee. Or if we have patients leave the hospital, they actually have to sign against medical advice form. I remember personally being in the hospital. I mean, I was chief resident at the time in a university in Saskatchewan. I knew everybody on the floor. They knew that I understood what was needed for me to come back if me and my wife went home after her delivery. They still told me I had to wait 6 hours before I was able to leave. I had to get the blessing of whoever was around that day to actually leave. And if I was going to leave, I'd have to fill out this 3-page form about why I left and that I understood I'd be harming myself and all of these other things. So even though patients do have control over a small portion of that power, we still make it very, very difficult for them to actually express it. So how does this actually show when you're seeing patients and when you're practicing as a healthcare professional. So when patients are entering into hostile situations where they have no control, have no power, there's decreased patient compliance. They can often delay. A classic thing is what's seen in cancer care, where a patient will present, have a bad experience, leave, come back 3-4 months later, now with stage 4 instead of stage 2 treatable cancer. Right? Increased risk of conflict, misdiagnosis, increased morbidity, increased mortality. From a healthcare practitioner point of view, there's increased frustration when the patients are compliant. Simple situations become very complex when things are delayed, or patients won't talk to us because they don't trust us. There's a tension that happens between patients and practitioners when there's conflict. So a lot of stress and discomfort. This leads to poor morale. There's increased complaints and boundary violations. As a healthcare practitioner, you come to work. Nobody's coming to work wanting to harm somebody. Right? None of us ever wakes up and go, you know what, I'm going to harm an Indigenous patient today. That's my goal. Right? But with this harm, we have increased risk of complaints and boundary violations. And these are devastating to certain individuals. I mean, some people question whether or not they still should be healthcare practitioners when these things happen. And then litigation and eventual verdict. So how do we make health environments less hostile and more safe for Indigenous patients? So these are the things that we know. So patient and family-centered care is an ongoing initiative within Alberta Health Services. This is the whole idea of taking a patient's values, culture, experience, and family and putting it central to care. It sounds pretty simple, but for reasons that we're starting to understand, we make it very complex for ourselves. Reflective practice, so it's the idea of looking at what are we doing and is it actually achieving the outcomes that we think it's achieving. You know, when I do something, is that actually adding to patient care or taking away? And then there's well-known best practices for culturally safe care. So cultural safety is a concept that originally came out of New Zealand back in the 80s. This has been around for decades. It's been well validated that this does make a change to patient care. And it's the idea that if we look at making healthcare environments less hostile, you're going to achieve better outcomes. And I think intuitively we all know that this is true. Making sure that Aboriginal patients are visible is one of the best practices. So you may see Aboriginal patients when you're seeing them in clinic or other places, but are they a part of the system? Are they a respected part? You know, do they have a voice? Do they have someone who's advocating for them? So these are things like the Aboriginal Health Program, Aboriginal health workers, cultural helpers. I know there's a well-run program in Edmonton that does this. These are people who help make Aboriginal people more visible, you know, viewed as equals in the system versus just clients who have no power. And then recognizing interlocking factors that contribute to culturally unsafe care. And this has been popularized in mainstream media. I'm very, very encouraged by the dialogue that we're having about colonialism and other historical factors. I want to be very clear again that people in general in health aren't out to harm people. I think in a lot of ways we're willfully ignorant sometimes. You know, we allow the system to do what it does because that's the way the system is always done. So there's social and historical factors. Patients see how we treat them and others, and so they expect the same sort of treatment, or practitioners expect the ability to treat those patients in that same way. Structural factors, so stress systems often bring out the worst in people. So if you're understaffed and overworked, your stress is going to have to come out somewhere, and regrettably that often comes out towards patients, especially those who are vulnerable. So obviously this seems very simple, right? And the truth is it actually is. So the question is, why haven't we already done something about it? So when I first got married to my wife, I had a really bad habit. I used to drop my socks, I'd roll them up, kind of chuck them across the room in a little ball. I don't know why I did it. I'll be blunt, I know this is wrong. I don't do it anymore. It led to a lot of conflict in my marriage early on. She'd leave my clothes and I'd sit there and go, you know, my mom always picked them up. You know, can you just pick up my socks? Like it's not a big deal. You know, I've been working all day, and I'll just stress again. I know that this was wrong. So my wife would sit there, and Wynn would go, "I'm not your servant. I'm not going to pick up your socks." And this, of course, led to lots and lots of conflict. And regrettably, there was a lot of fights that happened from this whole sock thing. And eventually, we had some professional intervention, and she phoned my mom. And she got on the phone with my mom, and she kind of explained this. And you know, my mom, she's a very wise woman. She was a great mother. She actually taught me much better than this. I'll say that too. She was on the phone, and she's like, "Wynn, you know, I'm really sorry. I taught him better than this, and you know, I'll have a chat with him and stuff." And so my mom gets on the phone with me, and she's like, "Oh, baby, you can't expect your wife to treat you like your mom. You know, it's different now. You're gonna have to change. The marriage is a two-way street, and all these other things, right?" So the suggestion that eventually came out is that we should get a clothes hamper, right? Roll up your socks, drop them beside the door into the clothes hamper. Once a week, take the clothes hamper downstairs. Problem solved, right? So the problem came when we had our first child, and I don't know about spousal experiences. I'm sure one or the other has a problem changing diapers. I have a huge problem changing diapers. I'm glad our fourth child is now like moving out of that, because I make a huge mess. I pour through a lot of wipes, like 2 or 3 packages. I have a big garbage bag size, you know, changing pad. There's like stuff flying everywhere, you know, and she'd ignore the dirty diapers, knowing that I was frustrated with it. And eventually I said, you know, my mom always changed diapers growing up, right? And I can't remember my dad ever changing a diaper in my entire life. And of course, Wynn goes, I'm not your servant. I'm not interested in changing these diapers. This is, you know, a partnership. We both need to support each other. Once again, I was a very, very bad early husband. So eventually she called my mom again, and my mom's on the phone kind of saying the same things. You know, I taught my son better than this, and he should know how to change diapers and all these other things. And then she got on the phone with me, and she's like, "Oh, baby, I know I always changed it for Dad, but that was just the way it was back then. You know, can't expect your wife to do this." And so the suggestion was we get a diaper genie, okay? So the diaper genie actually fixed the problems for a while. But the issue is that a lot of other things came up, right? There was mowing the lawn, there was doing the bathrooms, there was washing the dishes. Like, it just kept on going over and over again until we eventually got to the point where we agreed to disagree, right? We knew that we both had issues for some reason, and we were left angry and frustrated, right? So why did we get so angry talking about this? It kind of seems silly, right? It's dropping socks, it's changing diapers, it's washing dishes. These should not be things that interfere in a companionship of two people that decide to make a life together, right? Mm-hmm. And the question is how do we fix it? And does it mean that I need to give up my beliefs that my wife's not a servant? Which I will say straight out that I have given up that belief. And I do not believe my wife is a servant. Or does my wife need to kind of take on, you know, your mom did it, so maybe I should do it too. Mm-hmm. So when we look at point of difference between behaviors and beliefs, I dropped the clothes with the belief that my mom did it, but I looked at my wife leaving the clothes as being irrational, right? I thought, well, you're crazy. My mom used to do it. This is not a big deal, right? This is not a big deal. While my wife would leave the clothes, saying that she's not a servant, and look at me dropping clothes and being like, why are you being crazy? Just pick up your socks, right? This is not a big deal, right? And this, of course, led to a lot of anger and frustration. So we see this in the healthcare system in a lot of environments. So we're taught in current mainstream medical education that patients lead the healthcare team. This is a cultural change that's supposed to be happening across our system, and it's one that I fully support. But along with that, the belief is formed that patients will be mindful healthcare consumers if only we educate them, right? But the truth is, when a patient presents to the hospital, they want all the medical treatments, right? For the majority, right? It's a minority that wants to limit the access to care, right? And when you drill down to the essence of that belief, I pay taxes. I've never utilized the healthcare system before. I live in Canada. Medicare is part of our culture. You know, I am entitled to this care. You know, we take care of each other. And so, as healthcare practitioners, we look at patients and go, why are you being irrational? This doesn't make any sense. A classic situation from my residency training was we had a vial of something called activated protein C. And for people who work in ICU, I'm not sure if they still use this now, because I haven't worked in ICU for a while, but it's a very expensive vial. I think when we were using it, it was $24,000 or $34,000. And so there was a 3-page document, 3 or 5-page document that we fill out called an Apache 2, and had a bunch of these questions. But even when you gave it, there wasn't a whole lot of mortality improvement. But guaranteed, when you offered it to patients, they would always say, yes, give it, even knowing how much it cost, right? And so this, of course, leads to a lot of anger and frustration between patients and physicians. Patients look at us and go, why aren't you providing me the care I need? I am owed this care as a Canadian, or they are owed this care as a Canadian, right? Whether this is someone who's a citizen or not. I mean, new immigrants who haven't yet qualified to become part of the healthcare system or other things, often we get into these arguments about whether or not we should be providing care or not. And a lot of people in our patient-centered system go, well, why aren't you being a mindful consumer? So it comes down to belief differences. Now, beliefs are expressed in different ways, and I'll just touch briefly on power versus access, because we're running short of time. So the most compelling characteristic of the tools that I talked about earlier are the democratization of power. So if you look at how power is collected in information, money, and hiring, firing, as healthcare practitioners, we hold everything. We really have to give up our power in order for patients to be empowered. And that's not something that we often talk about. In order for a patient to have the time that they need with me, I have to allow them to have the time with me, or create systems or policies or procedures that enable that patient to let me have the time, right? Power and access, they're two separate issues within medical care, but we often confuse the two. Somehow if we provide better access, we'll do better empowerment. So access includes distance to service, so convenience, time to being served, wait time to receive service, efficiency. But the truth is, even if we increase the number of access points, if the power differentials exist in each one of those, nothing ever will get better. So I'll talk briefly just at the end of this presentation about Brian Sinclair as kind of a case study. Many of you are probably familiar with this case. He was a First Nations double amputee who had an indwelling catheter that eventually led to urosepsis. He died in a Manitoba ER 34 hours after he originally presented. So he was perceived without evidence of being homeless, a drug addict, a drunk, social assistance, awaiting police, non-compliant. This is all from within the actual inquest. So these are all assumptions that are directly attributable to statements that were made by people who participated in the inquest. So these are not things that I'm just saying. These are things from the actual court documents. Before he presented to hospital with his urosepsis, he was unilaterally placed on hold for catheter changes. Now, the person who was managing his care said that they were going to place him on hold because he was non-compliant. Now, when you look through the actual inquest, what you find is Brian was going to the ER for catheter changes. So he was actually being compliant with his care. He was getting changes every week as he was supposed to. But he thought, since he was getting his catheter changes already, what would be the sense in showing up for your appointment to get the same thing done? Right? So he was getting catheter changes every week, but it just wasn't with the same individual. And so, because the person who was managing his care never dug into it more, they just assumed that he was non-compliant when he was actually being compliant with his care. And once again, he died in the Winnipeg ER 5 weeks after waiting for 34 hours. When they found him, he actually, Rigger had said it, he'd been dead for several hours. So these are quotes from the actual court documents. I'm just going to read a few. So this is from the chief medical examiner. No doctor or nurse would lower their standard of care based on a patient's ethnicity. Doctors are focused on the medical condition. Doctors diagnose the medical problem that is presenting and decide what is in the best interest of the patient. So the CME is actually saying that there's no way that doctors can ever be biased in patient care. Now, when you look at what the student nurse said, she thought that the shelters may have been full. She had witnessed or been told about patients being discharged and nowhere else to go. She assumed that the person who had been in the waiting room since the night before was either homeless or had returned for shelter. And then one of the shift nurses on the second day. She did not really think about why he was there. It was not really her area to check his vitals. So once again, what do we believe about Indigenous people, and what types of caricatures were broadcast onto Brian Sinclair in these in this situation? How often do we either do it ourselves or see other people do it without us actually speaking up? So where do we go from here? So when confronting bias, it's probably more important to focus on how care is delivered instead of by whom, where, or what. That being said, even when it's clear that it's how care is delivered that's important, our system still focuses on whom, where, or what. And that's perhaps because of the ease of change. It's easier for us to change the scope of practice, it's easier for us to change the location of care, it's easier for us to change programs instead of changing people. Cultural competency, if you're using a very rigid definition, it confronts the knowledge gap of care. And we make the assumption that if we can change what people know, we'll change how they act. But we know this is untrue. How many things do we learn about, but never change our beliefs? Even very, very harmful things. We know that this thing could possibly hurt us or kill us. It's been well established. Or we know that this is just not true. The sky is not black. It's blue. Well, I guess it's black. But, while cultural safety looks at the belief gap that people have. So what is it about what they believe that influences patient care, and how do we bridge that belief gap? So we know things that work. Once again, patient and family-centered care, reflective practice, these best practices again. Employing these tools actually works. So in Saskatchewan, years ago, there was a creation of something called the Northern Health Strategy. Indigenous was involved in this. It actually changed health outcomes for the better for many of the health regions and First Nations in northern Saskatchewan. In British Columbia, there's been the creation of the First Nations Health Authority. They're trying to address this directly. In Alberta, I talked about before, there's the Aboriginal Worker and Cultural Helper Program. These are programs we need to support and expand. We need to find our champions in this area. When I'm asked about, what do you think is the eventual outcome? If you were looking at successes, what would be a success in the area of hostile health environments and Indigenous patients? It would be having someone in any healthcare situation being willing to stand up and say, are you doing this because of bias? Or are you doing this because of evidence? Right? If we could just have one person willing to stand up and make that statement, I think we have a culturally safe environment. And that kind of person needs to be able to stand up and be supported by our system. We need to link our actions to our outcomes. We need to ask the right questions. Often we respond to things that the community actually hasn't defined as being needed to respond. A lot of our research right now into Aboriginal health focuses on systems and processes, the what we do instead of the how we do it, even though that area of literature is being more supported. We shouldn't interrogate the experience. Perceived racism and perceived trauma are probably misnomers. It's just racism and trauma. If someone breaks their leg, you don't say, you must have perceived pain. No, they're in pain. They broke their leg, right? And that's the same thing with racism and these other harmful actions. We need to allow our Indigenous communities to advocate for themselves and to lead the way. And I always ask the question, how many of our Aboriginal healthcare leaders are Indigenous and/or community endorsed? Our Aboriginal chairs, our chairs of Aboriginal health at our universities, do we actually ask the question whether or not they're connected to community? Is that an important part of their selection process? Our people who are in about Alberta Innovates, do we ask the same questions? Now, these are individuals who I know are trying very hard, but we need to reevaluate what we value. Is it more important the number of papers in which journal they've been published in, or whether or not they actually have a connection to community and understand what's going on? So there are a few different things, just in quick summary. with Indigenous patients, we magnify all these issues because we combine power differentials with access issues in mainstream caricatures. People come with ideas already. And this is what makes bias particularly harmful to Indigenous patients. And this is why they cannot be grouped into other groups. We can't treat them like transgendered patients or immigrants or people from other cultures. There are specific things that happen with Indigenous patients, and we have to address them separately. We can change the system, but we have to change the culture. The great thing is we've done this before. We have a safety culture now. We have a waste culture that we're dealing with. This is just the next step in the evolution of healthcare, and I know we can do this if we work together. Thank you very much.
So much, Alika. So what I'm going to do, we're going to unmute the lines, but I think I'll start with the text question first, because I was told it takes a moment for the lines to get unmuted. So I'll start off. Great talk, Alika. You address the provider who believes they are competent in these skills, but is actually one of the worst offenders.
Sorry, say that one more time.
How do you address the provider who believes they are competent in these skills, but is actually one of the worst offenders?
I think that's a very insightful question. So thanks for presenting this. I think when you're looking at someone who's in that position, it goes back to power differentials again. So in medicine, we often promote people based on their education. We promote people based on the amount of time that they worked in the system or their connection with certain people within the system. But we don't evaluate whether or not they're connected with the community. And that's why that part is so important. We have to do an ongoing evaluation of our inputs and our outcomes. And I think individuals who believe that they're competent but end up being the largest offenders, you can actually draw a direct link between them having inputs that are not linked to outcomes. Now, that means that we have to measure it, and that means that when we actually have people coming out and saying what needs to be said, that we support them and provide a space for them to have that dialogue. I think we have that right now with the Aboriginal Health Program. It, of course, needs to be better supported. But people like Verna Yu, who's VP of Quality Improvement, she's been a huge champion for us. Richard Musto, who's a medical officer within Alberta Health Services. These are individuals that want to make the system better and are looking at actual outcomes. So if you have those types of situations, I encourage you to contact me. I tell everyone who contacts me that I keep everything confidential and anonymous, and I'm not interested in bringing out your situation unless you want it brought out in the way that you want. But I'll try and help you work through the system and see if there's policies that we can use already to kind of use to address your situation.
Maybe I'll open it up to your room in Grand Prairie, Alika, if there's a question from your room.
Sure.
I see it a lot, but I also see the white seniors. You see, like you shouldn't be here, your family should be here helping you. And it's horrible through the whole system, and I would like to report everybody. I think a little video camera in every room would bring honesty and authenticity to everybody, and if you know that camera is taking pictures of you, you'll be on your best. They do that with seniors' homes, right? One of the family members puts it in there. And I don't know, how do you stop it?
Yeah, and that comes back to my comment of we need to feel like someone notices, right? And that's the whole idea of making sure that Indigenous people are seen within our healthcare system. We have the ability in medicine to often do things with little or no repercussion. Right? If I do something, it's fairly easy for me to reason away, well, I did this for this reason, right? And the truth is most healthcare practitioners are smart enough to do that when they're trapped in a situation they shouldn't be. But that's why it's so important for one of us to speak up. The outcome of this presentation isn't to have you go into a deep depression or other things, which has been regrettably the outcome with certain people that I've talked to. But if we can have one person in every team who's willing to stand up, that's the watching, right? That's our camera, right? It's that person willing to stand up.
There are 10 minutes remaining in this video conference session.
Great, thank you. So I'm now actually going to open it up, and because I don't want to leave the audio line out. So is there a question from the people on the phones?
What can be done to promote data collection from Aboriginal patients in a more regularized fashion in the Alberta healthcare system, so we can track this information over time in a monitoring?
So data tracking was so data tracking was fairly easy when there's a separate healthcare system for Aboriginal patients, when it used to be all administered through the federal government, because you'd show up with your status card and everything would be charged, so you'd be able to track where care was accessed and other things. We often say in healthcare data collection that, well, it's not right to label people as Aboriginal, right? Even though we still do, using postal codes and last names and other things. So I sit with the National Surgery Quality Improvement Program for Alberta. So one of the things that we're encouraging our site to do is actually tease out ways for us to define who is Aboriginal and who's not. The National Institute of Health in the States has done this very well for Black patients. And information has come out that's actually shown when you have a long bone fracture in the States, you're actually less likely to get pain medication if you're Black. And when they drill down to what the essence of that is, it's often people have the idea that Black patients have higher pain tolerances than other people. And who hasn't heard about the story of the birch stick in pregnancy, right? So the Cree woman comes in to deliver and she bites down on a birch stick, and that's how she deals with her pain. So if that's your expectation, you don't offer an epidural, you don't offer fentanyl, you don't offer morphine. Do you know what I mean? So we need to find a way to track patients, and we have to quit giving ourselves excuses that somehow this is racist or other things. You know, the benevolent excuse that we have for not tracking patients. We have to find ways to tease out who is Aboriginal and who's not. And I think all of us can do data collection in our own way. There's a good book that I'd recommend you read. It's called Seeing Patients. It's by a guy named Augustus White. He's a spine surgeon from the States who's African American. He talks about a lot of this literature and mentions some other books that touch on this National Institute of Health information they've collected.
Great, thank you. Any other questions from any other telehealth sites?
Okay. Hi, my name's Jerry. I'm in from Rocky Mountain House. I'm the executive director at the Friendship Center here. And I was listening to the news, and I don't know how related it is to the presentation that we just witnessed, but on CBC or CTV, the late news, they did a random survey of health centers across Canada on reserve health centers. And it was with regards to competence of people working at the health centers. And I think of the 45 that they randomly tested, only one nurse met all of the qualifications. And I'm a white fellow. My family, my children are all registered. So I do have a concern about that. And I think there's a lot of fear, inner fear with Aboriginal people accessing the different facilities that are available. I myself, I go to Sweat Lodge because there are some things that I need that I can't get from Western medicine. And I think when the shoe fits the other foot or whatever makes the person comfortable with the type of care that they seek, they should be allowed to get that. Whether there's bias involved or not, I'm unclear.
Mm-hmm. I think it's a great comment. I'll try and just answer quick just because of time constraints. I was told by an elder and a healer at the last Wisdom Council that we need to treat traditional medicine as healthcare. You know, and this is going back to outcomes, right? If someone's able to go to a traditional medicine practitioner and have their asthma cured objectively, like things on PFTs and other things, shouldn't we be sending all of our patients to that, traditional healer if they can actually fix things permanently? And this is the experience of a lot of people who access traditional medicine that we often don't hear, except when we have those spaces where people are free to talk about approaching traditional medicine practitioners for their diabetes or their asthma or other medical conditions. We often minimize and delegitimize the experiences of these patients and elevate Western medicine, when really what we should be saying is we're focused on health outcomes. If this makes your health better, that's the purpose of the healthcare system. And what is it doing? It's offloading patients from the mainstream healthcare system, opening up access for patients who want to pursue care in kind of the mainstream manner. It's achieving better health outcomes, which leads to less cost, to the system, making things more efficient and sustainable and other things. But it's reframing the whole idea. So that's the first part. The second part with people having kind of competence in providing care, I think that it is a challenge. I think it's a challenge in rural communities as well. It, of course, gets worse and worse as you get to a more remote community. The truth is, once somebody gets their certification, they can kind of run off and do whatever they want to do as long as no one's watching them. That's the way our system is set up. So people don't know how to put in complaints properly. There's not really a mechanism within the system for them to change things. So the complaint system is designed not to take the 6-page complaint that the patient wants to give. It wants the one line of why something's wrong, the policy that they broke or the standard that they broke, and then what they want for restitution. But that's not the way that we're used to giving complaints as Indigenous people. We want people to hear our stories, right? Part of the process of healing is people hearing what the problem was, and feeling that they heard us and that there's going to be a change. And so we actually need to make changes in the way that we hear complaints, or we need to have people who understand that and then help Indigenous patients navigate the complaint system so changes can happen. Hope that answers your question.
Yes, that's great.